what are the options for patients with both VEGF resistant and IO resistant disease? So are there any biomarkers we can use to help guide us, or how do we make treatment decisions in this setting? Asim?
Yeah, I think, Ulka, this is a very important question, and this keep coming when we treat patients or when we got a phone call for second opinion. Okay, what we gonna do? Yeah, I gave IO, and then after then I gave cabozantinib, like, and then what we gonna do? I think the long story short, we don't have a biomarker like currently.
Yeah.
Although we are trying and we are collecting an IMDC and other cohorts. In addition to that, we also try to collect like a serial biopsies and blood work, and then try to come up a biomarker. But I think still we are far behind in terms of applying to a clinical setting. What I do in my clinical practice, as Matt mentioned, after immunotherapy-based option, I agree, cabozantinib, I think, is one of the best-in-class VEGF. This is what I do. And then after cabozantinib progression, like a Lenvima, Afinitor, I think is still a very good combination. I'm pretty sure all of you guys see responses, like after VEGF failure, I think Lenvima and Afinitor is still working. And if like this is an academic center, all of us are looking for a clinical trial also. There is evolving agents coming into scene that we're going to talk, I think, soon. And hopefully we're going to have better agents after IO and VEGF failure. But currently, I think still we try to come up our best sequence, like when we treat patients in our clinical practice.
Yeah, I agree with you, Asim, that this area there is a huge unmet need, because even with cabozantinib and lenvatinib and everolimus, I mean, granted, we have these options to help our patients. It's great to have third line, fourth line options in metastatic disease, but clearly we can improve upon them. And the best way to do that is by considering patients for clinical trials. Anybody else has comments?
Yeah, I mean, I think the field is really evolving, and when we're seeing these patients in the clinic, especially patients who may have received, an IO initially, can you treat them with another IO? Can you challenge them with another IO? This comes up constantly. If I'm going to give axitinib in the second line space and that patient hasn't gotten the axi pembro combo, I have this impulse to want to give them the doublet if they can receive the doublet, understanding that this is sort of a data-free zone, but trying to extrapolate from the frontline data. Or if somebody's never received Nivo-Ipi, but there may be post-Pembro Axi or other IO VEGF combo, when you're using Nivo, from the Checkmate 25 data, like, are you going to feel pushed to want to add Ipi? And so I think in clinical practice, I think we're doing this, but lacking sort of prospective data to help guide selection. I think there are going to be some studies that'll be coming out that'll be looking at the role of IO, post-IO in a prospective manner. And I think that's going to really help address an unmet need in the field.
Yes, and would be a hope that as you get different biomarkers, depending on the type of progression, you may be able to make a smarter treatment decision.
Yeah, and I would just like to add that, we're flying a little blind right now in terms of evolution of these tumors post cabozantinib or post lenvatinib and everolimus, and I do think we have a long way to go to understand, what pathways are being turned on and what we can think about in those settings, because it really feels like the earlier agents are not active post cabozantinib or lenvatinib, everolimus, as you would hope. The other thing that I would say, and this is just a shout out to Reina's work with the IMDC, where she showed that liver metastases and bone metastases were also independently negative prognostic factors when she was going through the IMDC. So those are part of how I think about patients as well, as where is their sites of cancer, what is their volume of cancer. And then the IMDC is tough because everything is a categorical variable. It's either yes or no. And when you have a patient who had their nephrectomy 11 months ago and now are progressing, if you start them now versus 2 months later, they're either 0 or 1. If a patient has the very mildest anemia possible, are you really going to give them a point? And so I think you still have to take the patient in front of you, their sites of disease, and then use the IMDC to help frame what you're going to do.
I absolutely agree, Matt. And I want to go back to your point about the refractory disease patients and how we're learning about the pathways that are turned on with patients who are resistant to cabozantinib or resistant to lenvatinib. If that patient is still a great, has great performance status and is still a clinical trial candidate, I agree with Asim that we should think about putting that patient on a trial. But I also am thinking about, potentially doing another biopsy, sequencing at that point, depending on, what is actually the treatment pressures have evolved and how the tumor has mutated in response to these treatment pressures. And so, could there be anything else targetable with, either an on-label or off-label treatment? Those are the patients that I'm selecting for biopsy and further sequencing.
Yeah, and I really think, it's such a epigenetically driven tumor. I really think we have to we got to get down to the protein level again and see what actually is happening at that level. We've been higher stream in terms of always looking at DNA, RNA. We are doing more transcriptomic work, but I think proteomics are going to play an important role for us as well.
Also, I wanted to remind, I think Matt brought up before that brain metastases is one area where really none of our typical agents are still performing very well. So that is where multiple patients are failing therapies, and we need better treatments for that.
Absolutely. I think I have quite a few patients who have great systemic control, as you mentioned, Matt, and then have disease progression in the brain. So we certainly need to understand more about, the microenvironment in the brain and why the mechanisms there that they're evading the immune system when they have such a great response everywhere else.
These were excellent suggestions in the discussion about maybe considering doing a biopsy, looking at genomics, and obviously looking at any clinical trials that you have available for the patients to enroll on.